Welcome all of my students to this class and hope all of you are in good health. My today topic is very important for you for your exam and rest of your medical life. That is pleural effusion. You have to face the pleural effusion in various parts of your exam system, like short case or in a long case, or X-ray in OSPI, or as X-ray in Viva table also. The classical presentation of pleural fluid in a X-ray chest PA view in erect posture is a curved shadow at the base of the lung, obliterating the cardiophrenic and costophrenic angle and ascending towards the axilla of the affected site. This is the classical presentation of pleural fluid in a X-ray chest PA view erect posture. Here, there is bilaterally the pleural fluid has uh, obliterating the both costophrenic and cardiophrenic angle and the base of the lung also. What is pleural effusion? What is its definition? Accumulation of serous fluid within the pleural space is termed pleural effusion. If blood accumulates within the pleural space, we called it hemothorax. If frank pus accumulate within the pleural space is termed emphysema. Why fluid accumulates in the pleural space? There are some theory or mechanism of accumulation of fluid in the pleural space. There are two types of actually pleural fluid accumulates. One is called transudative and one is called exudative. By the pleural fluid protein, we determine whether it is transudative or exudative or Light's criteria. I shall discuss later how we shall differentiate pleural fluid of exudative or transudative. In general, when pleural fluid total protein is less than 3.5 gram per liter, we called it transudative. In transudative case, the mechanism involved is increased hydrostatic pressure, capillary hydrostatic pressure in the pleural space, and also decrease the plasma colloidal osmotic pressure, and fluid accumulates into the pleural space. In case of transudative fluid, the mechanism is involved here, the increased microvascular pressure in the pleural space and causes accumulation of fluid into the pleural space. Now, the causes of pleural effusion. In our Davidson medicine, it has divided into two parts, common cause and some uncommon cause. The common causes of pleural effusion is pneumonia, that is, we called it parapneumonic effusion, tuberculosis, pulmonary infarction, malignant disease of the pleura or lung, and cardiac failure. Uncommon causes, that is, hypoproteinemia due to any cause, like nephrotic syndrome, where kidney is losing a large amount of protein, liver failure, where liver, we know almost all proteins are synthesized by the liver, mainly the albumin. 80% of total albumin is produced by the liver. Malnutrition or malabsorption, where intake of protein or gut cannot absorb the protein. So there is hypoproteinemia, decreased plasma colloidal osmotic pressure, and fluid accumulates in various parts of the body and also in the pleural space. Connective tissue diseases like SLE may cause pleural effusion. Post-myocardial infarction syndrome, acute rheumatic fever, Meeks syndrome, ovarian tumor, and pleural effusion. is called mixed syndrome, myxedema, uremia. These are the some causes of pleural effusion, common and uncommon cause. Among them, the pleural effusion due to cardiac failure or hypoproteinemia due to any cause causing pleural effusion are transudative type, and other than all causes exudative type of pleural effusion. How clinically, if you examine a patient of pleural effusion in the ward, and how you will understand the patient is suffering from pleural effusion due to any cause. First, examination start with inspection. You may found the chest movement of the affected side may be restricted. Palpation. During palpation, expansibility of the affected side will be diminished. Trachea and apex of the heart may be moved to the opposite side, If you percuss the affected part, you will find percussion node is stony dull. Stony dull term is always reserved for pleural effusion. If you auscultate the affected part, you may find absent breath sound, vocal resonance diminished, bronchial breathing or crackle just above the effusion. So this is our physical findings, and we can clinically suspect the patient may suffer from pleural effusion. What investigation you can do for your confirmation of pleural effusion? Radiology. We have already seen two X-ray of pleural effusion. X-ray chest PA view. X-ray chest always be done in peer view position and must be in erect posture. Posture. How you will understand as a X-ray chest has been done in erect posture? Patient radiographer may do a wrong, and he may take the X-ray chest in supine position. But as a clinician, we have to know the X-ray has been taken in erect posture. If the X-ray chest is taken in erect posture, you will find the funded gash on the below the left hemidiaphragm. You will always see it. So, and you will understand the X-ray has been taken in erect posture. How you will understand the X-ray chest has been taken in PA view, not in AP view? You will, if X-ray chest is taken in AP view, you will find that the vertebral column is more prominent, and you will understand that it has been taken in AP view, and heart size will be unusually enlarged in AP view. So by this thing, we shall understand that X-ray chest has been taken in PA view and in erect posture. At least 200 ml fluid is required for X-ray to diagnose it is a case of pleural effusion. At least 200 ml fluid is required, and it will obliterate the costophrenic angle, and we can understand that this patient is suffering from pleural effusion due to any cause. Ultrasound of the chest. It is a non-invasive and very much diagnostic. In X-ray chest, another term, pleural adhesion. Pleural adhesion may occur due to previous chronic lung infection, and it is sometimes it becomes difficult to differentiate by seeing a X-ray. It is either pleural effusion or pleural adhesion. The ultrasound is the answer in that case. Ultrasound is the answer. Ultrasound can of the chest can determine very small amount of fluid, even 15 to 20 ml of fluid. If it accumulates into the pleural space, ultrasound can diagnose it. And sometimes, if we suspect there is pleural effusion, underlying malignancy, uh, or any other chronic lung infection, we can go for CT scan of the chest. And but it is rarely required. Rarely required. Our clinical exam, X-ray chest, and sometimes ultrasound is almost 100% diagnose the case of pleural effusion. Now, we have diagnosed clinically or radiologically it is a case of pleural effusion. Then what we shall do? We have to do the pleural fluid aspiration and study. Pleural fluid aspiration usually done uh, manually, that is in the bedside, or ultrasound guided aspiration is possible. Usually aspiration is done in the mid-axillary and scapular line. If we aspirate in the mid-axillary, then 6 to 8 intercostal space. And if we aspirate in the scapular line, it is ninth or 10th intercostal space. And actually, practically, the scapular line is very much safe and very easy, and it is the most dependent part of the pleural space, and we can easily draw the fluid. After drawing the fluid, for diagnostic and sometimes therapeutic, where large amount of fluid has been accumulated and patient has respiratory distress, then we called it therapeutic aspiration of the pleural fluid. For laboratory investigation, it is called diagnostic aspiration. 70 to 100 ml fluid is sufficient for all investigation. First is the physical. Physical means you have to look the color and consistency of the pleural fluid. Usually, exudative causes of pleural effusion, the color is usually strong. Color is usually strong. In case of an consistency, a bit thick. If it is due to transudative cause, that is hypoproteinemia due to any cause or cardiac failure, pleural fluid is a bit watery and consistency is diluted. Laboratory investigation. First, we have to determine it is exudative or it is transudative. So pleural fluid protein is very, very important. In this context, the pleural fluid protein, how we can differentiate exudative from transudative. If pleural fluid protein is 3.5 gram per liter or more, it is exudative. If pleural fluid protein is less than 3.5, then it is transudative. Another criteria has been developed. It is called Wright's criteria, and I shall discuss later on how we shall differentiate pleural fluid either exudative or transudative. Cytology. Cytology will give us how many cells and what predominant type of cell they have found in the pleural fluid. As for example, they will give the total count of cell and the differential diagnosis of the cells. If the cytology shows the neutrophil count is more and predominant cell is neutrophil, most likely diagnosis is acute bacterial infection, that is pneumonia or parapneumonia diffusion. If it is lymphocyte is predominant, the most likely diagnosis for our country, it may be a case of pulmonary tuberculosis. Tuberculosis. So cytology is very, very important for to determine the cause of pleural effusion. Gram stain and culture. Gram stain and culture. It will determine the bacterial cause and specific bacteria and its sensitivity. In our country, tuberculosis is a very, very important cause of pleural effusion. So AFB stain and culture. Practically, we do the AFB stain and culture. We know there are two types of culture for pulmonary tuberculosis. One is solid media, another is liquid media. And usually it takes more time, at least 2 to 4 weeks also. So culture is not actually practically we do, but theoretically we have to tell FD stain and culture. Adenosine diaminase (ADA). It has good sensitivity for the diagnosis of tuberculosis. 93% it is sensitive for the diagnosis of tuberculosis. So adenosine deaminase has become a good test for us to exclude or include tuberculosis. Gene expert, it is more or less 100% sensitive. It is 100% sensitive for diagnosis of pleural effusion. In Gene Expert is not widely available, but in our select, this is Gene Expert is available, and we can do it without any cost. It is very much costly test, but Bangladesh government is providing it with free of cost Gene Expert. It has more or less 100% sensitive for diagnosis of tuberculosis. Malignant cell. Malignancy is one of the important cause of pleural effusion. So malignant cell can be seen in pleural fluid. Lights criteria. Lights criteria, it is highly sensitive for actually differentiate between transudative and exudative uh, pleural effusion. But for these lights criteria, you have to do extra test for diagnosis like pleural fluid protein, serum protein also, pleural fluid LDH, lactate dehydrogenase, and serum LDH also. You have to do this, and from these criteria, you can determine whether it is transudative or exudative. Exudative is likely if one or more of the following criteria are met: pleural fluid protein and serum protein ratio more than 0.5, pleural fluid LDH and serum LDH 0.6, pleural fluid LDH is more than two-thirds of the upper limit of normal serum LDH. If one or more of the following criteria are met, the pleural fluid is exudative or transudative. If we found it is a case of exudative, then hypoproteinemia causes and cardiac failure are excluded. If we found pleural fluid is transudative, then the causes are hypoproteinemia due to any cause like nephrotic syndrome, liver failure, or malnutrition, malabsorption, or from cardiac failure. So it is very, very important for us to differentiate the pleural fluid into transudative and exudative. Now, if a patient come to you with pleural effusion, then how you will evaluate a patient of pleural effusion presented to you? Number one, the history. Age of the patient is very, very important. If the patient is young, like 30, 25 years or 30 years, then malignant cause is usually excluded usually. If the patient gives history symptoms like patient has low grade fever, cough, chest pain of the affected side during coughing with a history of weight loss, and it is a prolonged time, then diagnosis is most likely tuberculosis. The most likely tuberculosis. In this regard, I tell a point that tuberculosis, pleural effusion due to tuberculosis is a extrapulmonary tuberculosis. We know tuberculosis are two types, pulmonary and extrapulmonary. 80% of pleural pulmonary tuberculosis, 80% of total tuberculosis is pulmonary and 20% is extrapulmonary. And tuberculous pleural effusion is extrapulmonary tuberculosis. In our exam, if we ask a patient, a student, uh, tuberculous pleural effusion, pulmonary or extrapulmonary, sometimes some students tell it is pulmonary tuberculosis, but it is totally wrong. Tuberculous pleural effusion is an extrapulmonary tuberculosis. You have to always keep it in your mind. If a patient give history of high rise of fever with sputum production, chest pain, breathlessness, and short duration of history, unless otherwise proved, it is parapneumonic effusion or pneumonia. So history is very, very important. If a patient give history of orthopnea, that is respiratory distress in lying condition, and sometimes you may found the patient has leg edema, engrossed neck pain, or enlarged tender liver, it is most likely that effusion has been developed from right-sided heart failure. Right heart failure. If a patient give history of loose motion for prolonged period and patient has developed also leg edema and thin skin and features of malnutrition, the most likely diagnosis of pleural effusion is malnutrition. So history is very, very important for your diagnosis, the cause of pleural effusion. If you come for clinical exam and you have found the patient has low-grade fever, patient body weight has been lost at least 3 kg in last 6 months, or a patient mm, become anorexic and features of malnutrition also, the most likely diagnosis is tuberculosis. If you found a patient with high rise of temperature, patient is deep snake, respiratory rate is high, and you have auscultated the lung, and you have found there is with pleural effusion, finding some pleural effusion and bronchial breath sound at the just above the pleural effusion, the most likely diagnosis is parapneumonic. Parapneumonic. If a patient of elderly age give you history, prolonged history of smoking at least 10 per year, and patient has losing it weight at cough at least 6 months, persistent cough for at least 6 months, and weight loss, the most likely diagnosis may be a cause of malignancy. Malignancy. So from history, clinical exam, you will 80% case, in 80% case you will find out the cause of the pleural effusion, and after that you will do the lab investigation of pleural fluid and sometimes the other radiological investigation, and you will reach in your diagnosis. And this in this way you will evaluate a case of pleural effusion in your ward. So this is something about the pleural effusion. For your betterment, I am again repeat this. What is pleural effusion? Accumulation of serous fluid within the pleural space is termed pleural effusion. Very easy definition, and you have to tell this in your exam. Accumulation of serous fluid within the pleural space is termed pleural effusion. Accumulation, if blood accumulates, we call this hemothorax. If frank plus accumulate, we call it emphysema. Then the most important question is causes of pleural effusion. You have to remember at least three causes of most common in pleural effusion. Number one is pneumonia, that is parapneumonic effusion, tuberculosis, and malignant disease, pulmonary infection, cardiac failure. You have to remember some uncommon causes of pleural effusion. Hypoproteinemia due to any cause, that is nephrotic syndrome, liver failure, malnutrition, malabsorption, connective tissue diseases, SLE, post-myocardial infarction syndrome, acute rheumatic fever, Meigs syndrome, myxedema, uremia. So it is very much easy. You will face X-ray in case of OSP, and you have to know some description, and you have to describe the X-ray chest in the Viva table also. So your presentation will be like this. This is a case of, this is a X-ray chest PA view showing the curved shadow at the base of the lung. In this X-ray, this is right lung, base of the right lung, obliterating the costophrenic and cardiophrenic angle. Most important is costophrenic, so you have to tell the costophrenic angle first and then cardiophrenic. Cardiophrenic. Yeah. So obliterating the costophrenic or cardiophrenic angle, ascending towards the axilla, right axilla. In this case, the effusion is the right side. So we are telling the ascending towards the right axilla. So this is a classical presentation of a X-ray chest showing pleural effusion, and you have to tell like this. Next question may be to you that what is the most important causes of pleural effusion. You have to tell at least three common causes of pleural effusion. Again, I am telling the pneumonia, parapneumonic effusion, or tuberculosis or malignant disease. Physical findings. Again, I am telling in inspection, chest movement may be restricted on the affected side. If you palpate the chest, expansibility will be diminished on the affected side. Sometimes, if there is huge pleural effusion, the trachea and apex may be shifted to the opposite side. When it is called massive, if you see a X-ray chest PA view in erect posture and you show the at least two-thirds of the hemithorax had been involved by the effusion, then it is called massive pleural effusion. Massive pleural effusion. At least two-thirds of the hemithorax is affected, then it is called massive pleural effusion. And massive pleural effusion may shift the trachea and apex of the heart to the opposite side. Percussion note, it is very, very important. You have to say if you found if there is effusion, it must be stony-dull, and you cannot say woody-dull or any other thing. Stony-dull term is only reserved for the pleural effusion. And auscultation, the breath sound will be absent, vocal resonance will be diminished, and sometimes bronchial breathing or crackle above the effusion may be found. And just I am repeating the just lab investigation you have to do with the pleural fluid, aspirated pleural fluid. Total pleural fluid protein first, it will differentiate exudate or transudate. Cytology, you will give some clue about the cell and predominant cell. If it is neutrophil predominant, then most likely cause is acute cause, that is pneumonia or parapneumonic effusion. If there is lymphocyte or chronic inflammatory cells are predominant, it may be from chronic infection like tuberculosis. Gram stain and culture, AB stain and culture, adenosine diaminase, ADA. ADA. It is very much sensitive. 93% it has sensitivity. Gene expert has good sensitivity and specificity. Gene expert more or less 100% sensitive and specific for tuberculosis. Gene expert malignant cell we also may found in case of malignancy. Now something about the aspiration of pleural fluid again. There are two types of aspiration of pleural fluid. One is diagnostic, another is therapeutic. When therapeutic is indicated, there is massive pleural effusion or patient facing some respiratory distress due to this effusion, you have to go for therapeutic aspiration. Therapeutic aspiration, uh, it is advised not to draw more than 1.5 liter at a time. It may cause re-expansion edema of the lung and may cause severe distress of the patient. So 1 or 1.5 liter at a time, and after aspiration you have to go for CXR PA view to see the uh, and to compare the previous CXR before aspiration and after aspiration. So this is something about therapeutic aspiration. So pleural fluid is very important, pleural effusion, and for your exam, for your whole life, and hopefully, if you read the Davidson medicine today about very small amount written in the Davidson medicine, and you read this today, it will be permanent in your brain and for your whole life, and you will be benefited from this approach. Thank you all, and see you again in the next class. Thank you.